This episode of Straight Outta Health IT is brought to you by Welling, your trusted partner connecting healthcare organizations, data, and innovation for a healthier community. Welling helps healthcare providers navigate complex challenges, from analytics and AI to workforce solutions and community health impact. Because at Welling, we believe when healthcare is connected, everyone thrives. Learn more at wellinkcommunity.com.
Straight Outta Health IT, the mic stays surgical. Christopher Cunny moves vertical, purposeful. Strategist with the vision, breaking every system's cage. Guests unfiltered, flipping chapters every page. Industry talk raw, no sugar, no varnish. From policies to tech, the convo ain't tarnished. Blueprints unfold, the future in the dialogue. Cutting through the static sharp like a monologue. Change makers in the building, can't ignore the sound.
Hello everyone, welcome back to another episode of Straight Outta Health IT, where we have an unfiltered dialogue about all things affecting health delivery, public policy, and health equity. I am your host, Christopher Cunny, and I have the distinct pleasure of being in Nashville, Tennessee today at the Meharry School of Global Health, and I am participating in our Innovation Moonshot Summit. And I want to, first of all, before we get started, I want to thank Dr. Dawes and Dr. Khan for their leadership and vision in initiating this Moonshot program. I think it's going to be transformational for healthcare, and it's just such a pleasure to be a part of this initiative as well. So let's get this party started. I've been in healthcare for over 25 years. And I've sat in more boardrooms, more vendor demos, more conference sessions, and more strategic planning retreats than I can count. And in all that time, all across those conversations, I have never been convinced that the decisions we're making in the next 3 to 5 years will determine whether artificial intelligence will be the greatest equalizer in history of American medicine or its most sophisticated instrument in inequality. This is not hyperbole. This is the actual choice in front of us. AI is already inside of every clinical decision support tool your providers are using. It's already inside insurance algorithms determining patient coverage. It's already inside risk stratification models determining which patients get more resources and which ones get fewer. And the communities most likely to be harmed by those systems when they fail, when the algorithms are biased, and when the training data is incomplete and the governance is insufficient, are those communities that are sitting in very front of Meharry's mission. I have the privilege of just finishing my first book. It's called Diagnosing Distrust: Why People of Color Don't Trust the U.S. Healthcare System and How the Technology Can Be Its Cure. And what I have found that we are at a very important inflection point. It is about trust. It is about accountability, and it is about our participation and engagement in it. So we're here today because trust cannot be assumed, it cannot be marketed, and it cannot be automated. It has to be built intentionally. Accountability and its genuine partnership with communities whose lives depend on getting this right. And that is our conversation today. So I have the profound pleasure of introducing 3 amazing superstars, change makers, and disruptors in this space today. And we're going to have an unfiltered conversation about responsible AI, civil rights, and community trust. I'm going to let each of them give their origin stories. And I'm going to start, first of all, with Tanisha.
I wasn't expecting to go first.
Yeah, absolutely.
All right.
You're right next to me.
We're about to do this.
We're going to make this thing happen.
Okay. Thank you so much for the invitation to be here with you all today at Meharry. It is wonderful to be in Nashville by way of Boston, Massachusetts, where we are celebrating in Massachusetts really 20 years of the Mass Health Connector, which was really one of the kind of origin policies that led to what we now know as the Affordable Care Act in the United States that was birthed out of Massachusetts. And I share that because I come from a place where health equity, health access, health for all is just part of our cultural DNA in Massachusetts. We're not there yet, but it is an ecosystem that is consistently striving toward that goal. I want to thank Dean Dawes and Dr. Khan also for the invitation, and how fabulous it is to be on a podcast today.
Pleasure to have
with
you.
you.
Thank you.
So I'm Tanisha Sullivan. I am the head of external engagement and health equity strategy at Sanofi. Sanofi is a global biopharmaceutical company headquartered in Paris, France. My work within Sanofi really focuses on how we partner across healthcare systems, community, and with policymakers to improve access, trust, and most importantly, patient health outcomes. I come into this work by way of the legal profession. I am a practicing attorney, have spent more years than we're going to talk about today, practicing primarily in the corporate health law space, and have also had a career within public service, having served as a chief equity officer in a public school system. And so my work really for my entire career has been about how we improve access and how we disrupt inequity.
Wonderful. Pleasure to have you on the show. Chris?
I guess I'm up next.
Yes, you are.
So first I want to start with 3 words. Some of you know because you've already spoken to me, but I'm a preacher, so you're going to hear that come through when I
Amen.
speak. I got 3 words in my spirit: gratitude, glory, and grit. Gratitude to be in this moment with all of you. Gratitude to Dean Dawes, Dr. Khan. Gratitude to my brother and my sisters here on this panel. And gratitude to all of you, because we need you to be a part of the doing and the solution building right now. Glory, let us revel in the moment. Because when we focus so much on deficits and gaps, and what is wrong and what is not working right, we might lose sight of the power and the strength that's in this room, right? I used to tell my students back when I was wearing my professor hat, may our thoughts collide up against one another and produce something beautiful. And then grit, it's gonna take us grit at a time where public health is under attack, health equity is under attack, Black folks are under attack in a nation that is still seeking to find itself. Right? As we dawn 250 years, we're still seeking to find ourselves. And so my origin story, it begins in East Orange, New Jersey. I am the daughter of 2 parents who lived through the Jim Crow South and who were a part of that great migratory pattern to go north for hope, to flee tyranny. I had a father that started at the famous Bell Labs cutting grass, and within 6 months was inside of a lab, never having gone to college. So I know personally the power of Black ingenuity to help solve, right? And Tanisha has heard me say this before, and to work alongside those who would ultimately create caller ID, 3-way calling, and Easy Pass. That was birthed in Black ingenuity, okay, at Bell Labs. And so that is the man who raised me. So can't was never in my vocabulary.
You go.
I was scared to bring home a B, y'all.
Absolutely.
And a mother that had a PhD in love.
There you go.
And neither of my parents went to college, but they cultivated within me a love of humanity, a love of community, and faith. And so I started thinking I would be the next Ben Carson, and I found out being the first Dr. Chris is perfectly fine.
Right.
Yes, I did. But literally, I fashioned a lot of my young Black life. I was in the 6th grade when I came up with this idea that I was going to be a neurosurgeon in my Black public school in East Orange, New Jersey. A lot of my life was, how do I become that thing? I didn't become a brain surgeon. I am a public health and preventive medicine physician. Yes. And I had to go through adversity, and I had to learn that success and life is not linear. And my career has taken me through several iterations as a public health and preventive medicine physician, whether in the labor management space with 1199 SCIU, so understanding the role of labor in equity and justice, whether as a C-suite health systems leader working at a safety net hospital during the pandemic, where I developed radicalization to stand up to the president of the United States and to say your policies are killing people, are killing my people, are killing my family members. And then landing at the NAACP as the director of their Center for Health Equity. So that's all the well that I draw from. And hopefully now I draw from this well too, as we build and we solve.
Thank you. And I think everyone in this room can appreciate your journey as well. I'm sure all of us in this room can cite one or many people in our families, in our communities that have inspired us to be where we are today. And so, to your point, we all stand on the shoulders of those folks who came long before us, who sacrificed, who encouraged, and who prayed for us to be where we are today. So thank you for sharing your story. And last but certainly not least, Kimberly.
Thank you. Yeah. We had a conversation last night where I was warned that this was not going to be your grandfather's podcast. I believe is what you said to me.
He can listen though.
And I came back with, well, I didn't have any grandfathers growing up, but I was raised by one tenacious grandmother.
There you go.
And prepared me to get on this stage today with you, and very thankful for that opportunity. My origin, I am local to Nashville now, but come by way of Pennsylvania, very central Pennsylvania, where that same tenacious grandmother was ignored for many years, over a decade, suffering from silent heart attacks that ended up taking over 75% of her viable heart muscle. And by the time someone listened to her, we were in emergency transport an hour away to the closest hospital for a 6 open heart bypass surgery. And as a 12-year-old girl, I stood by her bedside and stayed at the hospital for weeks, taking care of her and watching the story and the importance of adequacy, which fueled then my journey into healthcare. I started out in behavioral health, found my way here at Vanderbilt in Nashville. I am a hospital C-suite by core as well, lived through the pandemic as a hospital COO, a local CEO here, but now I sit in a position focused on women's health and women's services for Middle Tennessee. And being in that seat now, learning the tenacity for my grandmother, the patient advocacy, and now to have a space of creative autonomy in our community is what drives the conversation today.
Thank you for sharing. I want to share a personal story as well, and then we can jump into the conversation today, and why I'm actually here, and why I wrote the book, and why I'm so passionate about health equity. My mom I grew up in a small southern town in Georgia, 2 traffic lights. We had our local one primary care physician that pretty much saw everyone in the community. My mom would go on an annual basis to get her annual checkup. And during those visits, she would tell our local physician that, I noticed some blood in my urine. Is that okay? And he said to my mom, her name was Maddie, yes, that's fine. Nothing to worry about. Next year, same thing. This went over for almost 10 years. My mom going to her physician, telling him, she sees something that doesn't seem quite right. Long story short, it got so pervasive that they finally had to have tests. She finally had to have tests, and they discovered she had kidney cancer. And by the time they found it had metastasized. And a year and a half later, she was gone. We have to fix that. And I don't know if that's malpractice. I don't know if that's racism. I don't know if that's all of the above. I want to suspect in my heart it's probably all of the above, but we got to fix that. No one else should go through a situation like your grandmother, like my mom, or anyone else who has those stories. And we all have stories about family members who have experienced poor service in healthcare, poor delivery of care. And this issue around trust is permeated on generations of folks who have experienced medical atrocities. that have gotten us to a point where, as a coping mechanism, we just decide not to go and seek care, right? We say that's better than going and getting mistreated. And so I want to talk about, now we're in the age of AI, this possibility of how it can transform healthcare, right? And it's a double-edged sword, right? It can miraculously change what we do, or it can perpetuate the biases that exist. So share with me, Chris, I'll start with you. Share with me, one key idea or concern, innovation or approach about responsible AI that is really shaping your vision, your passion, what you're focused on today.
Yeah, so I'm going to start in the C-suite of a hospital where I had agency and I had some power. And we're in the pandemic, and we're talking about how we use a new software to help identify who's eligible for clinical trials. And on the face of it, that sounds like a phenomenal idea. But what was lacking was transparency. What was lacking was how would we explain to our patients and the community the benefits of such a tool, that it would be used, and why it was important for a safety net hospital to have access, right, to the power of technology to help solve problems. And we had a very unfiltered conversation that day, and a conversation that then led to some changes on behalf of, the hospital's decision-making. And I start there because you heard me talk about the power of innovation. We live on two sides of a coin because we live in several different versions of America. Many things in life have both a benefit and a risk for harm. I can't define one right now that does not. And in healthcare, in public health, in health equity, we are seeking to maximize benefit while minimizing harm. So when we think about AI, or when we think about technology, we in the NAACP, we realize that the only way we're going to save Black lives is to get in where innovation is happening, and to get in a way that forces the conversation to one that is ethically centered and has equity at its core. And so I'm not one of those people that says, we should have no AI, right? Because I've met some people to say, we should just reinvent how we solve problems without the use of things like AI. I've been a part of those conversations. And then on the other side, people saying, oh, AI is going to be the panacea. We recognize that we cannot allow digital divides to be perpetuated because our communities will be harmed further. So we started in a partnership with Tanisha Sullivan and Sanofi to think about how can we begin to solve health AI. And we have a public health initiative called Ace Your Health. At some point during this conversation today, I'll take you all to the webpage and ask you all to join up and to start to use the tools and the resources. But this is for framing, right? To think about what is possible. But in thinking about what is possible, to understand specifically the needs of communities that have been historically marginalized and or harmed or abused by medicine, healthcare, and science. With that lens in that frame, we are still going to be aggressive, right? We are going to be aggressive to ensure that opportunity is afforded to our communities. And so we embarked on a white paper, using the best minds and the best thoughts, but to say, what is an approach for AI that takes into consideration the safety net institution? What is an approach for AI that takes into consideration the federally qualified health center? What is an approach to AI that takes into consideration the Black grandmother whose physician continues to tell her there is nothing wrong, though there is blood in her urine? What is an approach to AI that takes into consideration someone who's living in a rural space, right, that does not have consistent access or a usual source of care? And with that, if we don't have that level of supreme responsibility in how we design, fund, innovate, and create, we know that we're going to continue to lose. And nobody here is interested in losing,
Right.
We've lost enough.
We lost too much
right?
already.
And so I think that's the frame with which we all need to step into this AI conversation. And then, wear that shoe. Walk in it, right? Live that life and live that possibility.
Tanisha's chomping at the bit.
So, I want to jump in here for a couple of reasons, but one, just picking up on what Chris shared. One of the things that I really want to lift up in this moment, it was referenced on the last, during a previous conversation we had. This work, when we talk about health equity, when we talk about AI and the intersection of the two, is not philanthropic. It is not philanthropic.
And what do you mean by that?
And what I mean by that is this work, if we are truly going to realize the potential for AI as a tool to help advance health equity and address health disparities, there has to be shared ownership and cooperation between and among government, the private sector, philanthropy, yes, nonprofit community. It is across ecosystems. There's a difference between how this work has historically been addressed and where we need to be. Historically, in this space, for a relationship between an organization like the NAACP, an institution, like the NAACP, and an organization like Sanofi has historically been philanthropic. We were very intentional in saying this will not be that. There's shared ownership, there's shared accountability for realizing its potential. The other thing I want to share goes back to something you made reference to relative to your mom. When I think about where we are in this moment relative to all of us being able to live healthy, thriving lives and where we can be, I am incredibly hopeful about how AI as a tool, and you'll hear me, as a tool, AI is not the thing, it's the tool, how AI as a tool can help us get there. Because what I consistently hear is for many of us personally and for our families and our community is that we are so reliant historically on healthcare providers to be the experts, to tell us what to do and what not to do, that we are often misdiagnosed or late diagnosed. One of the really pieces of gold and the power that's in these tools is that they can be empowering.
Yes, they can.
Right? No longer do we have to rely on the expert by education to tell us what could be or what should be. We actually may have in the palms of our hands the information to help guide and inform the conversations we have.
And I think that's a powerful comment, because I think what happened with my mom was a generational thing, that it was the white coat syndrome.
Yes.
Is what happened. She trusted and believed the man in the white coat had her best interest at heart. That's right. And the other challenge we have, and I do want Kim, I want you to jump in just a second. And the other challenge I think we've had historically in our communities, we don't talk about our health.
That's right.
I didn't know that was going on with my mom until years later, when she finally told us, what was going on with her. It's like, Mom, you wouldn't take your car to a mechanic and you had a flat tire and he kept telling you needed an oil change. Why do you keep going to the same doctor? Right. And whenever you see blood, that's not a good thing. Just as a human being, it's someone with relative decent intelligence. Why would you keep trusting someone that keeps telling you that something is not right with your body when you know it's not right? So I want Kim to jump in, because you work for a major health system that touches probably almost every state close to it anyway.
Close to it.
Yeah.
45 counties here in Middle Tennessee.
Yeah, jump in this thing and tell us what, your perspective and what your organization is doing.
Absolutely.
To get its arm around this issue.
Yes. So I think several things were said. As one of the largest nonprofit health systems in the country, and the nonprofit health system here in Tennessee at Ascension St. Thomas, we get approached often with the tool, right? It's going to solve this. It's going to do this for us. And one of the first questions we ask is, who is it serving? Because we serve all as a nonprofit health system. Is it designed to read and absorb the bias, or is it designed to change that? And when we look across our ecosystem, I have maternal units that are maybe 40% Medicaid, 90% Medicaid.
Right.
And when we look at our data, we separate that. It is not aggregated to hit the green mark or the gold star. We use it to drive and change clinical outcomes. Specifically, hypertension is a huge focus. If any of you know Dr. Connie Graves, she's the director of our perinatal services for Ascension St. Thomas, a force to be reckoned with. If you can find her, she's traveling all over the country all the time to speak on our behalf. But how many have been labeled hysterical, non-compliant,
right,
aggressive patient?
Difficult. Mm-hmm.
And where we see that impacted, OB patient shows up to the emergency room, high blood pressure, have those labels, sent home. Instead, we took a look at that and said, those protocols don't work. Those are built for a male body. Women are not small men. And work to change those protocols in our ERs to know it needs to be flagged sooner. She's not going home, number one.
Right.
The other thing we have been pushing over the last few years, care for every woman at every stage of life. Maternal health is incredibly important. We have a lot of work to do here in Tennessee. That responsibility is not lost on us on a health system, I can assure you. But we are more than our uteruses. And we are here to connect that conversation, absolutely. And to be a trusted, authentic partner in that conversation. And we have created a space called Her Health 360. We're on year 2 this year, and the intention is just that. However, we tell our providers, wear the white coat.
Right.
We want them at this free community event here in Nashville to sit down with you. You, as a patient, we encourage to say, you don't have a GYN, you want a new primary care doctor, come to that event. You get to do a 15-minute interview with a primary care doctor. You don't like them? Schedule with the next table, because that's what we're there for. And so just continuing to push that conversation. The 2 topics we really focus on, one, it's a free event, free access. We do not want financial barriers to be another resource that limits anyone accessing that information in the system. Do not assume for women that symptoms that we think are normal, blood in the urine decades ago,
Right.
bladder leaks, we think they're common. We have those conversations. They're not normal. Speak up, advocate, push back. And the secondary piece to that is the intergenerational medical history. It's a huge component of our education. The medical information or lack thereof can significantly change the screenings you need to be thinking about, considering, noting for your children. I think about my daughter. I think the heart history of my grandmother significantly changes how I need to look. And for years, I've spent a defense coping mechanism, even though working in a health system, ignoring the doctor's office. And it's taken a community around me to push me to go, to get past that fear that was ingrained in me, and to change the conversation, to make sure that I have access, my daughter has access, and to take away the shame and silence around that medical history.
Absolutely.
Chris, can I just
please,
lean into something
please
really quickly? Based off of what my 2 sisters just said, look, AI is either an equalizer or a multiplier,
That's
or
right.
it's a magnifier.
Exactly.
Right? And let's break down what the difference between that is. If AI, the way it is developed and designed and even funded, is not done through an inclusive process, we know that if the training data sets are not representative of all, it will perpetuate bias. We know that if we use synthetic data that is not representative and conclusive of all, it will perpetuate bias. We know that AI in these large language models in particular, they're going to hallucinate at a certain percentage. They're just going to make stuff up, right? And so with knowing that, There has to be a control, because otherwise it is just going to put a magnifying glass on top of all of the bias, the harms, and the potential that is already swimming around. But what you heard my two co-panelists say, unless we get involved in the tool, right, we won't have the opportunity to use it as the equalizer or the multiplier. And especially in communities where there is, I like to say, broken trust, right? Because there wasn't an accountability of systems, institutions, and organizations to develop the trust with community. So yes, for once, I had a mother who did listen to her doctors, other than her daughter who was a doctor. She listened to her doctors, right? Well, the doctor didn't say that. That's not true. And Dr. Oz, if he didn't say it, it wasn't true, right? As opposed to a father who was like, no, I'm going to follow the data. But we need to have a way that, for once, a person who has had a history of abuse or in a system, or a person that has had a history of, I'm not sure how to deal with this, can say, hey, I have an idea that I can bring, and we finally can have shared decision-making. Finally, shared decision-making. We finally can have patient-centered care. Because the last thing that I'll say, so I have POTS, and I was diagnosed with POTS over 20 years ago. And so we knew very little about POTS. We know more about POTS because COVID really has been a mass disabling event. Postural orthostatic tachycardia syndrome. And so I go into my cardiology appointment at UCLA. I'm going to name it, right? I'm an intern. My first year surgery, and I get very sick, and I don't know what's happening. I just get back from New Jersey, and I can't breathe. I can't round my patients. And I go in and I say, hey, something's going on. Oh, are you stressed out? Are you nervous? Are you anxious?
Right.
And I'm like, no, I just was on a month's vacation. I can't breathe. And then ultimately, I pass out. Then ultimately, I'm found that I have an ejection fraction that's 35%, because I've been sick for so long, and people have been telling me that there's nothing wrong with me. And then one day, I remember my father saying, we're talking at the lab. There's another physician, a woman, and she says, call her if you need her the next time you go into your appointment. I said, no, I got it. I figured out what was wrong with me. I had to take a journal article into my cardiology appointment to say, this is what's wrong with me. And if we don't treat it, I'm going to hurt myself. Imagine the power of AI.
Right. That's right. Exactly.
That's what we're talking about.
Right. The promise of it. Absolutely.
Correct.
And thank you for sharing your story as well, too.
AI is transforming healthcare, but modern care depends on infrastructure that cannot fail. Cisco's AI-ready unified edge securely unifies operations, the resilient infrastructure that modern healthcare demands.
What's exciting and also a little scary about AI today, truth be told, is we're building a plane and flying it at the same time right now. Every day something changes with AI. And everyone's talking about, efficacy and, accountability. How do we ensure it does no more harm than good? But the reality of it, this thing is changing every damn day.
Yes, that's right.
So how do we put guardrails in place, to prevent the discriminatory outcomes that it might exist, in AI, from both a civil rights perspective, from an industry perspective? What policies, what governance mechanisms? And it's okay to say, hell, I don't know. We got to figure it out. But if you got answers, we'd love to hear them, because that, at the end of the day, is what's going to determine whether or not we actually can make this moonshot a reality, right? I'm going to just put it out there and let any one of you jump in that one.
So what I'll say is we have to do both.
Right.
Fly.
Right.
And work to ensure accountability.
Right.
That's critically important. And I say that because this, to your point, I would argue it's every day, it's literally every second the thing is moving, right? And so if we spend too much time in the lab,
right,
trying to figure it out and what should we do and kind of pontificating and debating, we are widening the gap.
Absolutely. And God forbid we wait on our politicians.
We cannot do that.
That's right.
So it's flying. So it is continuing to bolster our individual and collective AI fluency, learning how to interact with these tools, again, individually, and ensuring that we're working in community to do that, while also working in partnership to build frameworks. And I'll let Dr. Chris talk about the frameworks that we've built together, building frameworks for ethical use of AI that is inclusive, that is responsive to community, and that most importantly, centers patient health outcomes.
Great.
That's critical.
Before you jump in, I'm going to ask Kim, though. Again, large health system, you guys are rolling out AI every day. You're in these meetings, you probably have an AI governance committee or something.
Everything has a committee.
Absolutely, yeah, management by committee. Talk to me about what guardrails you guys are putting in place.
Yeah, I think that's incredibly important, but at the same time can't slow us down.
Right.
And influence the conversation at the design level. I think a lot of health systems can be deterred by wanting the final product and at the end. And I would say less than a policy and a committee, Ascension's taking a stance that the guardrails, we're engaging early as a part of that design to break that. And I would also say, yes, the plane is in the air and we're flying it at the same time. Multiple planes, some in jets, some in helicopters. Some planes are still on the ground.
Still on the ground.
And as a health system, I would say too, I mentioned we actively look at, the bias. Does it read or absorb it? And is it designed to remove it? And you think about the words I said, hysterical, aggressive, non-compliant. The accountability is still on the ground with the health system though. That equity and education training is still on the health system and our nursing schools and our med schools, and even post 5 years, 10 years, that 20-year nurse, that those charts are being reviewed. That education is on us because those words shouldn't even be in the health chart for AI to remove. So I think that's the other piece, that as a health system, that accountability and responsibility is not lost on us, that we are still needing to fix the systemic issues on the inputs into the AI that's on the plane.
Yeah. And so to combine with what both of you said, so I talked about Ace Your Health earlier, right? You can go to any search engine, and if you put in NAACP Ace Your Health, it's going to take you to a landing page. This is this large public health initiative that we partnered on. And one of the main deliverables of that partnership has been a health AI white paper, building and bridging a healthier future. And something that the white paper calls for, in addition to what we've already discussed, is a framework. And the framework that it calls for has 3 layers. And it's what you said, Kim, is right. So it has this ethical framework that says that, 1, we have to make public and transparent the tools and the resources that institutions and organizations are using, so that scenario that I described to you in my C-suite does not happen. Right? So whether that is through a public dashboard, whether that is through relationships in community to help develop fluency, that is something that is a part of that ethical layer, right? Taking information out of the closet and putting it in the domain of the public. Okay. And so in addition to that, it has to be organizational. That's where actual governance committees have to come into being. And there must be power within those governance committees to answer those questions that I said before. Who's training data? Right? Are we using synthetic data? How was the data created? It has to say, what is the rate of this thing lying or hallucinating? It has to say, where is their bias and how are we removing it? But the health system also has to say, who created this thing? Were they inclusive and representative of all of humanity? And we have to begin to use the power and the agency and the weight of the particular institution that we live within to drive accountability. And then finally, operational. Evaluation has to be built into any tool or resource that you're doing. And also the evaluation has to be built into any governance framework. We got to evaluate ourselves. Right. Are we achieving the outcomes? Is it having the impact that we have? And we have to ensure, and this is where the NAACP as that cultural institution, and the word that Tanisha used, influency, going in community and ensuring that you have equal understanding, right? Or equitable understanding so that you can drive accountability. And then the last thing that I would say is that where does community have power? Right? Where is community leveraging its power in this process? Are we a part of those governance committees? Right? Are we holding not just institutions, but elected officials responsible and accountable? And this is where the issue around data centers, right, comes into play. We can't have a conversation about AI and it being ethical or equitable about talking about the potential harmful environmental impacts that are happening as I heard on this stage yesterday, the digital redlining that's happening. And we in the NAACP are very hyperbolic, right, in that lane. My partner at the NAACP, Bray Connor, leads our Center for Environmental and Climate Justice. And the NAACP has released a communities frontline framework to say, how are communities stopping where AI is being used in a harmful way, meaning data centers aren't using the latest or safest technology, right? Who built this data center, right? So sometimes they're operating and you don't know that they're operating, right? Or they're expanding and you don't know that they're expanding. Exactly. And the last thing is, what tools are we using? In the NAACP, we understand center equity, we understand the power of research, and we also understand the power of litigation. Right? And so recently there was a lawsuit against Elon Musk, right? And their XAI in Memphis. So there is a way to do this, and then there is a way to demand that it's done properly.
Thank you. Thank you. Yeah, please. Yeah. I'm going to ask you a provocative question, if I haven't already.
There's more?
Yeah, there's more. What's an acceptable error rate for AI? People make errors all the time.
Look.
And AI is going to make errors. We see hallucinations all the time. What's acceptable?
So what's acceptable is striving for a tool that does not have errors. Right, like that's what's acceptable.
Right. But we use it anyway.
The standard should be it's accurate 100% of the time. Recognizing.
Do we demand out of people?
I think what we demand is excellence out of people. Mm-hmm. This is a tool.
Okay.
And so again, I would submit that we should that our expectation is that tool is correct 100% of the time, recognizing that it will fall short. And that's where having the guardrails and the frameworks in place can help ensure accountability for when they do inevitably fall short of that. Whether
then who's held accountable?
Held accountable for
when it falls short.
I think that's part of the work. Okay. And it depends on where the failure is.
Okay.
Right? It depends on where the failure is.
Mm-hmm. Yeah. And so as a physician, I don't have to tell you all know this because you've lived it. We have an unacceptable rate of medical errors. We're not even talking about AI.
Right.
Okay, let's close the computer now. I'm not even talking about AI. I'm talking about surgery on the wrong side of the body. I'm talking about writing a prescription right there on rounds and the decimal point is in the wrong place. Right? I'm talking about me sitting in an ER with a young man who's having an allergic reaction and a healthcare provider rushing in and about to give a cardiac dose of epinephrine. And then realizes it at the last minute and runs out because they have traumatized themselves because they were about to kill a young kid who came in to stop an allergic reaction. So if we're going to have a very provocative conversation, we have to have a conversation about errors writ large, right? Then if we want to focus it on AI, we have to have the frame that we talk about in quality and safety of never events. Like Tanisha said, there is a goal of never making an error, but we know in actuality it happens. You should never go into the hospital and come out with a hospital-acquired infection. But it happens, right? And there are rigorous systems that have been set in place to minimize and lessen the chance that it happens. We have to have that same type of rigor, I'm gonna back us up, around racism.
Right.
Rigor around medical racism, racism in care, bias in care. Don't have the fallacy that suddenly discrimination has been introduced into the equation because of AI.
That's right.
Discrimination has always been in the equation. So we have to take that tenacity into AI to say, where are the accountabilities? There are individual accountabilities, but then the more power is the organizational accountability.
And how can we have AI hold us accountable?
Exactly.
Right? Looking at
work
the
on
data
that
and
one.
asking the question from an equity and racism perspective and say, why did you treat that patient differently than the other person?
Yeah.
Absolutely. Ms. Wells, you want to jump in that? Okay. It's getting hot over here.
But this is the right conversation, and these are the right questions.
That's right.
That we have to wrestle with now.
That's right.
Not later.
That's right. Before we put it in place and it's too late and we cause harm.
That's right.
Exactly.
We cause more distrust. We cause more gaps in care. And I want to ask one final question, and we'll open it up for the audience as well too. How do we get past Tuskegee and Henrietta Ladd in trust? And now that we have AI. I know, right?
I'm looking down the other end. I'm gonna let y'all start.
Do you want me to go?
Yeah, jump on it.
Okay, first of all, we get past it by not calling it Tuskegee. Okay, let's start there. Because it was the United States Public Health Service study.
Well,
but it's important.
Go ahead.
Language is important in framing, right?
Yes.
Because that too has caused harm.
Absolutely.
it has caused harm. And again, I'll start with a personal story, right? And so I told you about my father. My father lost his life in the pandemic. He died of COVID, April 13, 2020. And my father lived with chronic HIV/AIDS, right? And his infectious disease doc used to always say, Tim, it's not the AIDS that's going to kill you. It's not even the HIV infection that we now have caused to be undetectable. It's the smoking, right? And so we would laugh and we would talk about it, but basically the smoking was a setup. His lungs were destroyed, and then he got COVID and he died. But I say that to say my father was in the hospital right before COVID struck, November 2019. COVID was already there, but we weren't talking about it openly. He's in the hospital. He goes in with a ruptured aneurysm in his lung. So he's coughing up copious amounts of blood. He's in the hospital. They stabilize him, but then things go south and he has to be forwarded. He has to be moved to an acute care floor. He's being rushed down the hall. It's about 2 or 3 in the morning. And the doctor says, watch out, here comes HIV.
What?
In 2019.
You're kidding me.
Watch out, here comes HIV. I don't have to name Tuskegee. I don't even have to name Henrietta Lacks. We have to be able to talk about those experiences that are happening on a daily basis, multiple times a day, that are allowed to exist within healthcare, allowed to exist. Nobody in that moment held that peer accountable, okay? The way the accountability happened in that situation, my father panting, barely able to breathe, days later would be intubated, called my brother, the bishop, and said, you have to come here right now, because these people may very well kill me tonight.
Right.
And then they didn't even tell me that night. They told me the next day, because they know how I am. I'm going to show up.
Right.
But I knew how to get to that CEO. And I said, you have to fix this. You have to fix this for the person who doesn't have a Dr. Chris in their family.
That's correct.
Right? And so that's what we have to begin to drive, right? And I'm going to say it again, y'all. Yes, we should be talking about both the potentials and the harms of AI, but we got to deal with the larger systemic issues that AI is existing within, right? And when we begin to have the guts, the bravery, and the courage to deal with that, then we can customize it for this particular, as Tanisha keeps saying, and rightfully so, tool.
Yes. Kim?
Yeah, I second that. Yeah. In terms of AI is a tool. We're still on the ground fixing part of the solution. And in not even 7 years, tomorrow, I don't want to see words like hysterical, non-compliant, aggressive in a women's chart. Not anywhere in my hospital, in my health system.
Right.
And that responsibility, that accountability, holding everyone accountable from the ground, from that ground level before it even reaches the plane, is the story that I focus on, the story that needs to be brought in partnership, the many sectors, organizations that we partner with every day. It's the uncomfortable conversation. It's the provocative question.
We have to have them.
We have to have it.
Yeah.
And we have to be honest.
That's right.
As a health system, we say zero harm.
That's right.
It doesn't happen.
Yeah. Yes.
It doesn't happen.
Exactly.
And the transparency in that is key.
Absolutely.
We can only learn from the transparency.
That's right.
Something real quick, and I know we got to go.
Sure.
Real quick. Okay, so I'm sitting in my office, and another C-suite executive is sitting across from me, and he tells me to my face, Chris, the only reason I'm doing these things that you're now trying to impose in the hospital is because I think this part of it is easy to perform. But otherwise, I don't believe in equity. Someone told me that in my office. I am the Chief Strategic Integration and Health Equity Officer, and he tells me I don't believe in equity. And unless the CEO makes me do it, I'm not going to do it. Right? That is the problem that we're talking about, right? And so then hospitals go through these processes to do culturally responsive care. And that's where partnerships like this have power, right? Because they begin to say, how can you have, now, we're beyond having courageous conversations. How can you begin to drive accountability in actions and solutions?
Sure.
And what does sharing power look like? And when we fail to share power, gaps, disparities, and inequities remain. When we learn to share power ethically and equitably, that's when we begin to erase, narrow, and subtract.
Thank you. Questions? Yes.
We have a line of questions.
Okay, come on up.
This is fantastic. I'm Kim Smith. I didn't introduce myself earlier. A second-year PhD student in the Global Health Equity program. So I have a question, kind of linking it back to connecting maternal health and AI and predictive medicine, but I want to give context. In South Carolina, my husband's paternal grandmother was pregnant 18 years in a row and gave birth every time with a midwife in her home. That same county today is a maternal care desert. I happened to be in that county 14 years ago on the verge of a maternal health crisis and didn't know it. Made it back home, thank God. Unfortunately, was diagnosed with HELLP syndrome, lost my daughter, Lauren Kelly, which is a severe version of a life-threatening hypertensive disorder pregnancy. I can't get out of my head what my mother-in-law said. Thank God Kim made it back to Richland County. Thank God she made it back to maybe a physician on call, someone who knew what they were doing. The same county that can produce healthy babies, 18 in a row, is a desert, and people are afraid to even stay there. So my question is one of responsibility around what a powerful tool like AI can do to address this disparity, knowing that maternal health is a looking glass to future cardiovascular disease. What are our hospitals doing, those that have had to or chosen to pull out of those rural communities that still serve those members, on how to use AI to predict disease, engage with them in a way that's innovative, beyond just telemedicine, beyond saying we have digital health, but in a way that is strategic, that shows these are breadcrumbs that can lead to X, Y, Z. What are our hospitals doing today, not in the lab, but in the communities today, with a sense of urgency because people are dying and they're making life-threatening decisions based on how they feel because they've got to drive 45 minutes to get to care.
Absolutely. I'm going to let you have that one, Cam.
I would say specifically, I can talk about our system here in Tennessee. We have 3 centers in the state that deliver babies in the 45 county stretch. One of those currently is delivering 0.8 babies a month. Okay? That unit still has to be staffed 24/7. The provider still has to be staffed 24/7. That is not a financially viable business decision. I can tell you that. If someone was looking straight at the P&L, that they would not keep that open. But we have committed investing in the last 2 years, significantly in the last 12 months. We are not going to become another OB desert here in Tennessee. 60% of Tennessee is deemed an OB desert in our system, in our market. We will not become another one. If we close the next closest hospital, women would have to drive 2 hours to reach the closest. We can't invent doctors overnight. We can't invent OBs overnight. I can't change Medicaid reimbursement or policy overnight. While we're still having those conversations, we're investing with other partners. FQHCs have an incredible space here in maternal health. And we have an FQHC who has midwifery as a secondary service. They will be opening up 3 clinics in that region, Upper Cumberland here, if those in Tennessee, McMinnville, Tennessee. So not only that one center where the hospital is, they're expanding with us to create a new hub and spoke model. It's also not financially viable for them. But we know that pregnancy is the window to future women's health care. We care about the women, her whole stage of life. We also know that this FQHC, one of the questions we asked was it's all-encompassing, so wraparound services, primary care, mom and baby specifically, as we know the influence on 0 to 8 years and what that has for an economy. So we're looking outside of ourselves and saying, who's that right partner? Who's willing to take on and tackle something that maybe doesn't make sense when you look at the P&L, but it makes sense for community health?
And just as for time, I'm going to let, okay.
I love it.
Next.
Thank you. I'm Tracy Coleman, a second-year PhD student at Health Law Policy and Management. Thank you all for your time today. Chris, thank you for leading the discussion. I had like 3 questions. I'm going to choose one, seeing as though we just
You can ask them after the discussion.
I know. I said, okay, which one is the most important? But this one, I think, is really resonating with me. So we talked about Henrietta Lacks and the U.S. Public Health Service experiment at Tuskegee. Thank you for grounding us with that. We've seen what happens when innovation moves faster than ethical safeguards. As I work in AI governance every day with development teams, I have mentioned on a few occasions and raised for our AI governance board the notion of treating, as we were testing the systems, how can we hold AI developers and deployers accountable, similar to how we do it here as a research institution, as we all take city training and have to know about how we have to come forward to institutional review boards and understand how our research, may impact communities. I really feel like there's a void among AI developers and really understanding some of the things that you guys raised today about how these systems can cause harm. So just how do you think we could explore something like that or do something like that? Because it's really, you're building a tool and you're not even considering some of the instances that were raised today.
I was just going to quickly comment on that. That's what we're doing today. That's why we're here. We have to build a pipeline of the next generation of Black and brown healthcare technologists, professionals, informaticists, clinicians, who are all a part of this equation. I want my non-melanated folks too to be a part of this journey with me, and we want them to see value in who we are as human beings, but we also know that we're tribal in nature. We trust people who look like us, and those people are going to have our view and perception, hopefully most of the time as well. So I applaud institutions like Meharry, who's developing these next generation of leaders in this space, because that's what's going to be, to me, the catalyst for change. And I'll just give you this last comment as well, too. In 2006, I was vying for a CIO position at a large, very respected institution. And I went to the retiring CIO and asked him what his succession plan was. And he didn't have one. I said, well, hey, I'm interested. What do you think the opportunity is? And he looked me in the eye and said, Christopher, I'm going to be very honest with you. This institution has never had a person of color in the C-suite. And I don't think they're planning to do it anytime soon. He said, you're better off going somewhere else and finding your way into the C-suite in another institution. Long story short, much like I can tell you after the fact, I became CIO at that organization, despite the obstacles. But this was 2006, and we still have these biases at all levels in the organization. So all of you are in these programs. I applaud you for taking the leap and sticking to it, because we need you to be the voice, the face, the advocates, the change makers, the disruptors in this space as well, too. Otherwise, people will still have that view like he had, just less than 20 years ago. Next.
Hi, my name is Brittany Littleton, and I am a second-year PhD student in the Health Law Policy program here at Meharry. And I am also a native Nashvilleian. So, Kim, my question is for you because I am a maternal health advocate, and that is my interest. We talk about AI being a useful tool, but when it comes to the current governance, especially federal level governance of data, how can we use AI to combat that when data is currently being restricted, especially around reproductive health?
For a health system like ourselves, we start with our own data. We're not going to allow the controls and limits to be on our own data. We serve thousands of lives every day. And that goes back to my point of the intentionality with our provider leadership saying, we're not going to aggregate this. We're going to take the hard look at our own stories by population and not just take the gold star or the CMS rating, and take control. Look internally and influence from that level up. We can't allow those barriers to slow us down.
Hi, I'm Courtney Christian. I'm a second-year PhD student here in the Health Law Policy Management program. My question is a little bit different. I work in the biopharmaceutical industry, and so a lot of our member companies, I work for the trade association, are starting to use AI in medicine development. So my question is more about how do we ensure that bias is not baked into innovation?
Yeah. So I'll jump on that one. So yes, all across industry now, AI is being used, and we are experimenting with AI tools on the research and development side of the house. And I think part of the answer goes back to what Chris said earlier around AI governance frameworks. I think it's critically important in the absence of federal, state, or local oversight by way of policy and or regulations, that institutions individually and collectively have robust AI governance, internal AI governance frameworks, by way of committees or other aspects of infrastructure to support oversight within those organizations. That's one. The second is, I do think there is a role for trade associations to play in helping to hold our collective organizations accountable. Okay. The last piece I'll say, because it's probably the last time I'm going to get the microphone, so I do need to say this. When we think about using AI as a tool, and I bring this into the conversation from my legal background, I think about, like all of the things that go into determining what a system might look like, how a tool may be used, how we address care gaps. And I think about all of the legal work that needs to happen. Right, all of the due diligence that needs to happen, all the research that needs to happen. AI has the potential not only to help fill care gaps directly, but it also has huge potential to radically impact the amount of time it takes to get to a decision to go or not go. Let's not lose sight of that. It's not just at the bedside, it's also all of the things that oftentimes can take months, if not years, to have in place before a decision can be made, we can radically reduce that time, which can thereby have an indirect impact on care delivery.
So we're going to have to leave it there. We'll drop the mics. This conversation will be continued. Thank you, everyone. Thank my amazing guests for joining me on the podcast. We'll be posting this soon, so look for it. Straight Out of Health IT. You can find it on all the major podcast channels. If you like what you heard today, please like, share it with your friends, colleagues, even people you don't care too much about, because everybody can benefit from these amazing women's thought leadership and conversations. So thank you, Meharry, for allowing us to have this. Thank you, everyone.
Where the talk stay free, tune in, turn up, this is where you wanna be. Data-driven dreams, they decode the code, hack the status quo, make the old ways implode. Gusts dropping gems like pockets of gold mines. Healthcare's front lines, redesigned in real time. Honey got the mic, architect of the chatter. Revolutions in the air, healthcare's new chapter. From telehealth to equity, nothing stays unseen. This is more than a podcast, it's the dream machine. The system's pulse is beating to the sound, voices of change.